Production costs for the following program, Here's to Your Health, are being provided by Leland Memorial Hospital in Riverdale. Now, Here's to Your Health, a program which lets you talk directly with various health professionals. Here's your host, Jerri Fuller Cole.
There aren't too many times of the year that are more pressure-filled and more stressful than this time that we're in right now. And stresses can take their toll on our health in many ways. One of the ways that we're going to be discussing tonight is headaches. We're going to be talking about different headaches and how many headaches are actually caused by stress and what we can do about it. My guest is Dr. David Satinsky, who is affiliated with the Neurology Center. He is Associate Director of the Headache Center, which is affiliated with the Neurology Center. He's also the Director of the Biofeedback program of the Neurology Center. And he spends a great deal of his time as a neurologist treating patients with headaches. So I think he's more than adequately prepared to talk about this subject tonight. He is also an assistant clinical professor of neurology at George Washington University, and I'm very pleased that you could find time to be here this evening, Dr. Satinsky.
It's nice to be here.
How widespread are headaches?
Almost everybody gets headaches, as you may imagine. It's been estimated that about 70% of Americans will visit a physician at some time because of headaches. Sometime
in their lives?
Yes. So that's a significant majority of the population.
It's got to be a pretty bad headache to go to the doctor about it, probably.
I would think so.
Yeah. Are most or how many of headaches are caused by a disease process? Or are they, how many of headaches people get are a symptom of another more serious problem?
While most of our patients that come to us because of headaches suspect that they are ill in some way, in fact, in reported series, it turns out that somewhere between 95 and 98% of patients who go to a doctor with headache do not have a disease. They are in perfect health.
Isn't that surprising? Did it surprise you? Of course, you spend a lot of time treating patients with headaches, so I guess that wouldn't have been a surprise to you because those are the people you're dealing with day in and day out. But I find that to be a very shocking figure. Yeah. I would think that more people than that would really be ill who had headaches.
One might think so, but in my practice, which is already screened by the family physician, don't forget, the neurologist usually gets the case on referral. Even in my practice, which is the end of the road in terms of screening, the significant majority of our headache patients have no disease.
What's giving all these people headaches then?
That is a long story, and I'd like to go through it briefly. I envision pain as originally intended to be an indicator of either malfunction or damage, and I think one would have to agree with that. When people develop a backache, for example, from bending and lifting something too heavy, they know to lie down because the pain will diminish, indicating to them that their body is healing. When we develop a headache, instead of assessing what happened to cause the headache and circumventing that behavior until the headache goes away, or permanently avoiding that behavior, most of us, if not all of us, continue to do those behaviors which cause the headache. And this may be as simple as having the alarm clock go off in the morning, driving through rush hour traffic, working for a boss who loads more work on our shoulders than we feel we're capable of handling. And this cannot be avoided, of course. We all have to earn a living. So the behaviors that cause the pain continue. We do not alter those overt behaviors. What we will see perhaps in the discussion as it evolves is that it is possible to alter the behavior of our bodies in response to these environmental stresses and thereby reduce the cause of the pain. But instead, most people initially reach for a bottle of aspirin or some analgesic, not realizing that the pain is an indication that they are either overworking or damaging their body, and that is the reason they hurt. And then if the over-the-counter analgesic doesn't work, they go to their physician hoping for some simple solution, which is perfectly human. And if he is not able to provide that, then they often are sent off to the neurologist, and that's the patients that I see. And the majority of these people, as I say, do not have a disease.
Okay, you said that you made the point that most people can't change a lot of the circumstances about their lives that have to do with jobs or living in the city or families or things like that. These things are going to be there. But you mentioned changing the behavior of the body. Can you give some examples of what you mean in reference to that?
I would like to do that. But before we get to that, I guess there's a medical pathway which I'm accustomed to following in order, and that is first one has to determine the reason for the symptom, and then one has to treat that reason.
Okay.
So why don't we first sort of wipe off the question of physical disease.
Okay.
Because it's the smallest percentage of our patients, and although it's what everybody worries about, it's not what we should spend most of our time talking about. There are ample organic reasons for headache, ranging from infection in the sinuses, needing eyeglasses, brain tumors, cervical arthritis, or arthritis of the neck, head trauma, as an example of a physical reason for headaches. And it's the physician's primary job, that is to say, his first job, to find out if any of these physical diseases exist. And so he will have to take a careful history, examine the patient, and run whatever laboratory tests he deems are necessary. It is only at the end of that workup process that the physician is entitled to start to treat. It is not appropriate for him to, in a summary fashion, determine that it's a tension headache, for example. But anyway, after the organic workup is over, and I don't think the purpose of this program is to discuss the treatment of sinus headaches or brain tumors, the physician then has to sit down with the patient and say, you know, there is no organic disease that I can find. Let's talk about your life a little bit, and let's see if we can uncover what might be happening that's responsible for these headaches. There are factors which will single out certain individuals for headache more than others. There is a hereditary tendency for migraine, for example, which is rather strong. 70 or 80% of migraine sufferers have a immediate relative with migraine, a parent or sister, child, something like that. So the physician can begin to anticipate that he's going to be dealing with migraine headaches from part of the history, the family history. There are certain habits that can be ascertained very easily. The amount of alcohol one drinks, the amount of coffee or caffeine that one consumes, the amount of cigarette smoking. And we all have been threatened to death with what's going to happen if we keep smoking, drinking too much, and having too much coffee. But it's a fact that all of these things will interface with our tendency for headaches. And the worst offenders being the alcohol and the caffeine, believe it or not. So that people who are drinking upwards of, should we say, 5 or more cups of coffee, tea, or caffeinated soda per day are setting themselves up for a headache situation.
Well, you know, as you mentioned, headaches being associated with stress, the caffeine certainly does add to the amount of stress that you're dealing with.
Yes, but all of these three intake problems, smoking, alcohol, and caffeine, they are all responses to stress. They are all ways that we hope we're going to avoid the effects of stress. And of course, there are instances where it simply compounds those problems. Anyway, once the organic problem is laid to rest, one then has to help the patient to decide what is he or she capable of doing at that moment to reverse the headache situation. Is analgesic medication all that is appropriate? Well, there are times that that's the case. For example, it's not uncommon for women to have headaches clustering at the beginning of their menstrual cycle. And in those instances where there are no headaches at any other time of the month, I think it's reasonable to try to find a medication to be prescribed 1 or 2 or 3 days a month, and if it works, the problem is solved.
Right.
And I don't think it's necessary to get involved in behavioral changes in that situation. The converse is the patient who comes in and for the last 15 years they've had a headache every day. This is not that uncommon. And it should be obvious that getting involved in medications is not going to do very much good, and it doesn't. The over-the-counter medicines didn't work. That's why they're in your office. And narcotics are absolutely contraindicated in this situation. It will only make them worse. The tranquilizing medications, such as Valium, have an ameliorating effect immediately, but that doesn't last long. And then you have a person with headaches who is also habituated to Valium. So the problem is greater than a simple solution with medications. And those are patients who really have to attend to their behavior.
Does the solution to the problem, in some cases, have to do with the program that you're involved with called Biofeedback?
Yes, indeed. And we have, in our practice, treated by now thousands of patients with biofeedback. We have evaluated the responses in terms of headache frequency and headache severity, and we have evidence from our own patient population that biofeedback in the majority of patients will significantly reduce the problem, if not clear it up altogether.
Now, a lot of what we see in the press about biofeedback certainly doesn't suggest that it's not credible, and I don't mean to suggest that to you, but a lot of the articles that come out tend not to emphasize the scientific aspects of it, and I'm sure that a neurologist would not be using this method of treating problems unless there were a scientific basis for biofeedback. Can you tell us something about it?
Unfortunately, the groundwork for biofeedback did take place in more of a metaphysical area than a scientific one. And it was used to enhance certain states of mind. It was used initially in hopes of enhancing creativity. There were some relatively non-specific and unscientific approaches that employed biofeedback initially. But as the field has changed over the last 13 years, and we've been in it for that long, it has now become an important element in the management of all chronic pain patients in the legitimate pain clinics that have sprung up over the country. It is used legitimately in the management of hypertension. There have been studies from physicians at NIH, physicians elsewhere, on the use of biofeedback for hypertension or high blood pressure. There are now studies published over the years on the use of biofeedback for urinary incontinence, and there's certainly nothing more objective than urinary incontinence. So that biofeedback is now a legitimate form of treatment for a host of truly organic symptoms, in addition to all of the supposedly non-organic symptoms such as anxiety, insomnia, headache.
How would you apply biofeedback in the cases of your headache patients? What kinds of things would you do to use biofeedback?
The non-organic headaches, that is to say, headaches not due to disease, fall into two general fields, two general camps. The most common is the tension headache or muscle contraction headache, in which the cause of the pain is chronic tension of the scalp, face, and neck muscles. And for those patients, the mainstay of treatment in biofeedback is to train them, or they train themselves really, to loosen up the involved muscles. As simple as this sounds, it is very difficult. And it takes training week after week, hours of sessions with the biofeedback therapist during which the muscles are being monitored for their state of tension, hours of practicing at home, plus just time is necessary to alter one's behavior, one's physiological behavior. The migraine patient has what is referred to as a vascular headache, which means that the pain is coming from the blood vessels themselves in the scalp and in the neck. And the pain really comes from the expansion or dilation of the arteries in the scalp and neck. The nerve endings in the walls of the arteries are stretched as the arteries expand, and those stretched nerve endings hurt. The goal of therapy and the goal of biofeedback in these patients is to enable them to shrink back down those dilated arteries, and they can learn to do it with biofeedback. The training doesn't apply directly to the arteries of the scalp, but rather to the circulation in general. And usually the modality that's used is to put a wire on the fingertip, which is hooked up to a temperature monitor, and it records the skin temperature of the finger. And the patient is trained to warm their hands, voluntary warming of the hands, which will restore the circulation and other things to a more normal pattern.
Now, these are things that you do to teach a patient to get rid of a headache once it has occurred, or can you do things to teach a patient to prevent the headache from ever happening?
Mm-hmm. As biofeedback training progresses, the patient initially learns how to carry out these physiological changes, and they begin seeing that when a headache begins, they can abort the headache with these phenomena. As they go through the rest of the training, and particularly if they continue to practice for a month or two afterward, they then discover that they aren't getting headaches anymore. They don't have to use the technique. And the reason for that is they have really reshaped the connections between the mind and the body. They have altered their physiological state on a permanent basis through training, just as an athlete alters his muscular and neuromuscular state by training.
Can you give me some other, this is fascinating, when you said you put the wire and teaching the person to warm their hands and then they change the circulation. Are there other examples of ways that this biofeedback would work to get rid of a headache?
Those are the two major modalities for headaches, is muscle relaxation and hand warming. And I would say that there are other ways in which biofeedback is employed, but not really very much in the management of headaches. So I think we should drop it at that.
Okay. How many of, I should mention for the listening audience who may have tuned in late, I'm talking this evening with Dr. David Satinsky, who is a neurologist affiliated with the Neurology Center, and we're talking about headaches, treatment and prevention of. How many of headaches, now you said since the vast majority of headaches are not caused by a disease process, and you were talking about the biofeedback methods that can help people to get rid of a headache, and then eventually they stop coming. Other than through these biofeedback methods, are headaches preventable?
Headaches are at least theoretically preventable, but again, if we're looking at a person who is locked into a situation which has created his headaches, it may require behavioral changes of a very limited nature. I should also comment on foods, which we've touched upon a little bit, and that is there are other foods that lead to migraine headaches besides the alcohol and the caffeine, and they are, in particular, red wine, sometimes other types of wine and other alcoholic drinks, chocolate, and certain types of hard or aged cheeses. These are the major offenders for patients with migraine. There is a long list of foods that certain migraine patients are sensitive to. A very small minority, for example, will be sensitive to chicken livers or to pickled herring or citrus fruits. And the list goes on, actually. But that's a very small percentage of people.
But the major categories of food that you mentioned, the cheeses and the other items.
Chocolate, hard cheese, and your red wine.
I would take it because this would be due to some chemical present in the food.
Yeah, that is true. And the assumption is, and it's got some scientific basis, that there is a dilating chemical in the food which causes the arteries of the scalp to dilate, just as a natural migraine headache would cause them to dilate. And that's what the patient then experiences.
Okay. So you recommend if the person is experiencing migraines, if migraines is the problem, you tell them to leave these foods alone as much as possible?
I ask them to examine what they have eaten in the preceding 6 to 12 hours, or if they are eating these things practically every day. Mm-hmm. If they don't eat them regularly, then they really should just look at what they've eaten in the 6 to 12 hour period before the headache. And if the same food keeps coming up, they should certainly eliminate it. And that has to do not just with the chocolate and cheese, but any of the others on the list. Skin testing for food sensitivity works occasionally in migraine patients. It doesn't work at all in tension headache patients. And there are mixed reports as to the importance of these true food allergies in the etiology of migraine.
What's the importance of other lifestyle factors, such as a person's sleeping habits or their exercise habits and things like that, with relationship or respect to their tendency to get headaches?
Tension headaches are going to be reduced by anything which reduces the effect of stress on the body. So certainly regular exercise and regular sleeping and eating habits are going to be good for your tension headache patient. Migraine headaches have an unusual response to changes or to abnormalities of lifestyle. Getting different amounts of sleep every night is bad for migraine, but one peculiar quirk that migraine sufferers have is that too much sleep on one night of the week may trigger their migraine. And there are patients who only get migraine on weekends. They'll only get it on Saturday or Sunday, and they'll have it when they awaken in the morning. The reason for this is that they sleep later on Saturday or Sunday morning than any other day, and the extra sleep is what does them in. And these patients are instructed to set their alarm and get up at the same time on Saturday and Sunday.
That's interesting. Are you familiar with any studies or just from your own experience in treating headache patients? are there people who get them more often, or more? Are there certain groups of people, or do women get more headaches than men, or do older people get more headaches than younger people, or can you draw any pictures of the people who seem to have the worst problem with headaches?
Certainly, there are age factors. Migraine can begin even before a child learns to talk. You can surmise that an infant has headaches because he'll cry and perhaps hold his head. But as soon as children can talk, they can tell you their head hurts. And migraine can begin, therefore, demonstrably at the age of 2. In women who happen to get more migraine than men, their migraine will usually change as they go through the teenage years, and then will change again at menopause, usually getting better at menopause because of the loss of the estrogen cycling. If they continue to take estrogen orally by prescription after menopause, they may continue to have the same migraine, of course. As one gets very old, and I don't want to admit what that is, the arteries are no longer able to distend the way they used to, and the migraine slowly goes away. So there is an advantage to developing hardening of the arteries. I'm not sure it's worth the trade-off.
Okay. What about between men and women, or any other groups? Are there any tendencies?
Well, tension headaches are probably as frequent in men as women. Migraine is certainly more common in women. There's a form of vascular headache similar to migraine, which occurs predominantly in men, called cluster headache, which fortunately is much less common than migraine, because cluster headache is a terribly painful headache. It's apparently the worst kind of headache that there is in the healthy population. There are other causes of pain in the general area of the head, however. I should say that aside from toothaches, which you have to go to your dentist for, and problems you need to see the ear, nose, and throat doctor, like sinus headaches, there are truly, some people need glasses and they're going to get headaches. So we have to look at all of these patient populations in a sense in their own right, but they make up a very small percentage of the headache population.
Okay. It appears from a number of the things you said, Dr. Satinsky, that you do not, in most cases, advise using medication to cure headaches.
Well, what I try to do is to get patients through the acute painful period with medication and convince them, if possible, that by altering their inner behavior, they will then not need the medicine permanently. So I do prescribe medication. I have no problem with that. And there are patients that take it permanently. And there are circumstances, financial, time factors, and even just motivational factors, which prevent some people from going through a behavioral modification program.
Okay, such as with biofeedback.
Yes.
Do you find that a lot of your patients have experienced headaches for a very long period of time before they come to seek professional help?
Yes. Most headache patients have had headaches for years. It's the unusual patient that shows up with a brand new headache, and that, of course, is the one you really worry about. The chronic headache sufferer probably almost surely has no disease. Once in a while you'll find one, but usually has no disease unless the headache has changed its character. But the person who shows up with a brand new headache, and he didn't have headaches before, is a significant concern.
Because there's more likelihood that it could be...
There's an acute problem.
And the headache is so bad that he has to go and get help, is that it?
Not that it's so bad, but that he never had them before. Now, there's always a first headache, but it usually occurs pretty early in life in people who are going to have bad headaches. So that the average adult who has bad headaches will tell you that they've had headaches since they're either in junior high school or grade school.
You mentioned the migraine headaches having a very large genetic factor. Do you think that is true, or is there any evidence that the genetic factor would also play a strong role in the types of people who get the other type of headache?
That's an interesting thought. There is a family history of headache even in tension headache patients. The problem with the data is that the usual dogma is that maybe 50% of people with tension headaches will have a family history of headache. But if one looks at the fact that perhaps 70% of the population has headaches, well, you haven't proved anything. But you can show that migraine patients have a stronger family history than tension headache patients.
Interesting. So those are the two basic types of headaches, the tension headache and the migraine?
Yes.
Okay. With the biofeedback that we've talked just a little bit about earlier, and if someone has been suffering from a problem like headaches for a long period of time, such as years, as you mentioned, can they learn to do the kinds of changes that they need to do in their reaction to stress within a couple of months, or is it something that really takes a very long period of time to iron out?
The average patient in our practice takes about 3 months to get through it. That's plus or minus several weeks. So that it's very unusual to find somebody who can accomplish what's needed in less than 2 months. And once in a while, a person will stay on in the program for 4 months or even longer before it clicks. I suppose it's similar to learning to ride a bicycle. If you can remember the experience where you never thought you'd learn, and your father was running alongside of you, and you continually would lose your balance until one golden moment when he let go. He knew when to let go of that seat, and you didn't fall. And from that moment on, you had it. And I don't know what happened at that moment. Something in your brain finally figured it out. And I think biofeedback has some kind of a threshold phenomenon like that. It doesn't occur very suddenly, but it occurs like that.
And your patients who do learn to use biofeedback to get rid of their headaches, once they have a skill, it's like riding the bicycle or learning to swim or something, they have it for good and they can go back and...
Mostly. We do have people come back for refreshers, so to speak, because their headaches come back after a few years. And it takes them maybe 1 or 2 or 3 sessions to relearn what they had forgotten because they hadn't practiced.
Is it something that they need to keep on practicing?
Some patients need to practice regularly in order to maintain the gains and to avoid the headaches. Others never practice again and never get another headache.
Never need to.
That's right.
Isn't that interesting? And you've been working with the biofeedback for, we said, 13 years?
Yes.
Have you been able to draw any conclusions about how it works or why it works during that period of time?
Well, we have, over the years, incorporated more and more into our work the analysis of the patient's attitudes and general lifestyle. So it is not simply the control of the muscle tension or the skin temperature by itself, although that's part of it. But if you analyze the data from centers that only trained these physical changes, their success rate is not as high as in those centers that deal with other behavioral aspects of life. So it's a total package. You're taking a person who reacts in a certain constellation of behaviors to stress, and you're trying to approach as many of those factors in his behavior constellation as you can. And the more of them that you approach, the greater the success will be.
Okay. I'm interested in what you just mentioned about the patient's attitude and how that affects some of the questions about preventing and or curing headaches. But we are to a point, 7 o'clock, and here's to your health, where we do need to pause for a brief station break. I am talking this evening with Dr. David Satinsky, who is the Associate Director of the Headache Center and the Director of the Biofeedback Program. Both the Biofeedback Program and the Headache Center are affiliated with the Neurology Center. And we'll be back after this brief station break for the second half of Here's to Your Health.
Hello, this is Michael York. Consider how important the teeth are for clear speech. Now think of a child developing speech habits to use through life. It's clear that the primary teeth, or baby teeth, are very important indeed. They also help to shape the face, to guide the permanent teeth into a straight position, and of course they're quite useful for eating too. So take good care of your child's teeth. For a free booklet that can help, write Children, the American Dental Association, Chicago 60611. Right after.
This is Allie McGraw for the March. For that real role right now. The stage directions are important. Visit a clinic or doctor early and often. Eat properly. Exercise in moderation. No smoking, drinking, or drugs. Good prenatal care helps prevent birth defects. Wise direction from the March of Dimes.
WGTS-FM, Tacoma Park, Maryland.
Hi, I'm Jerri Ann Fuller. You're listening to Here's to Your Health on WGTS-FM from Leland Memorial Hospital in Riverdale, Maryland. I'm talking this evening with Dr. David Satinsky, who is affiliated with the Neurology Center. He is the director of the Biofeedback program and associate director of the Headache Center of the Neurology Center. He's also an assistant clinical professor of neurology at George Washington University and treats headache patients daily in his practice as a neurologist in the Washington area. We're talking about headaches, why we get them and how we can not get them. And during the second half hour of Here's to Your Health, we do open up our telephone call-in lines to questions from the listening audience. Our telephone number is 270-0101, 270-0101. If you have a question, we'd be happy to hear from you. And just before we paused for our station identification, Dr. Satinsky, you were mentioning something that we haven't talked really a lot about. We talked about some of the lifestyle factors, which for the most part, as you said, people have to get up and go to their jobs. They have to fight the traffic. In many cases, they have to deal with unpleasant people and a lot of the other stressful factors. But you mentioned one key word that I'd like to talk about a little bit more, and that has to do with the patient's attitude towards the lifestyle. And I was wondering what part that plays in a person's headaches.
It's very individualized, of course, but perhaps the commonest, should we say, error in conceptualizing one's life is to imagine that so many things in our life are really important, that they really matter, and that the outcome of a particular event is going to have long-range implications. That we really believe that so often, and it is so often untrue. And this business of taking our lives and the events in our lives too seriously, that perhaps singles out many of our headache patients from the remainder of the population. Type A versus type B behavior has been written about quite extensively in the last 10 years or so. And we find that the type A behavior, namely the time-conscious individual who takes the events in their lives extremely seriously, as though they're very important, these individuals tend to have more headaches.
Interesting. So do you advise people to take it easy? Is that part of the professional advice for people who suffer from headaches?
It's not necessary. And we can deal with patients who hold two jobs, that work 16 hours a day, that go home, that clean up the house, that raise the kids, that do a million things. We can deal with them. And it may work out as long as they don't take their small trials and tribulations too seriously. And that's a major attitude problem. The perfectionist is the characteristic headache patient. And the newspapers have to be picked up off the floor, the chairs have to be placed back under the dining room table, the laundry has to be washed and put back in the drawers. All of these little perfectionistic things are ways of dealing with life that our patients do, which reflect an attitude of, after all, how important is it for the paper to be in one place instead of on the floor? Does it matter? And yet, patients don't seem to feel the lack of importance of these events and these things. So there is an attitude there which has to be dealt with, and it takes time.
Okay. We have a caller standing by. Let's see what our caller has to say. Hello, you're on the air.
Good evening. I'm very interested in the subject, and I'm only sorry that we didn't have this biofeedback years ago. I was an individual that was subject to very severe headaches, and I had an administrative position, and I think, Doctor, I was what you would call a perfectionist, and very conscious of time. Everything had to be organized, and everything had to be a few minutes ahead of time. And I'm aware that certain number of people have certain characteristics which are prone to such a situation. I remember that my father, who also was a perfectionist and an engineer, he had such terrible headaches that it was hard to imagine that anyone could stand them. And now I realize that they were caused by the fact that he was such a perfectionist and always wanted to do things absolutely right at all times. And I think that these are the characteristics that cause these things. And over the years, after I retired, I put things in perspective, and I must tell you that I don't get any headaches anymore because I have taken the attitude if that piece of paper is down there a little while longer or if the chair is out of place, it's not going to change the world. And so I realize our attitudes have a lot to do with the headache factors.
I'm very glad you called. Thank you for your comments.
Thank you.
Thank you. Telephone number is 270-0101, and we do have another caller standing by, so we'll go to that person right now. Hello, you're on Here's to Your Health.
Hi, I have a couple questions. One is I have a history of migraine and tension headache, and I know a lot about those kind of headaches. But I also have another type of headache periodically, which is associated with exertion. And I wonder if the doctor can say something about those kind of headaches, such as running up the stairs or screaming at a football game or something.
And these pains are still in your head, is that correct?
Right. They're generally sub-occipital, where the tension headaches are.
Are any of your headaches on just one side of your head?
The migraines are associated with this menstrual cycle.
Mm-hmm. It's not uncommon for migraine patients to develop exertional headache or exertional migraine. And it may require a lot of exertion, such as going out and playing football in the end of August when it's hot, or it may only require running up the steps. There are migraine headaches that occur only at certain times during sexual activity, for example. There are patients who require being overheated as well as having exertion. So there are all kinds of variations on the theme, but exertion triggering migraine is not uncommon, and my feeling is that that's probably what you're experiencing.
So you're saying that it's a vascular kind of phenomenon?
Yes, it's generally a vascular headache and can be treated if treatment is needed as a vascular headache.
Okay. The other question is, I've just been learning about type A and took a test and scored very high, which surprised me. And I wonder if you could suggest any kind of book. I'm getting ready to read something about it, but I wonder if you could suggest something helpful.
Friedman's new book, I don't know how new it is anymore, on the treatment of type A behavior would be an excellent book.
Okay.
Thanks for calling.
Thank you.
Okay,
Bye.
good night. And we have a couple of other callers standing by who are waiting patiently, and we'll ask you to keep on waiting because there are two of you. And our telephone number is 270-0101 if you have a question about headaches. Hello, you're on the air.
Hello?
Yes.
Hello. I'm calling Dr. Satinsky.
Yes.
I have a question for him, and that is, my daughter has migraine headaches, and he suggested that statistically it's a good chance that they come from a genetic or relative effect. The only relative I can think of would be my sister, her aunt, who was epileptic. And my question is this: if there is a causal relationship, or can be, between those two facts, and if Dilantin offset the epileptic seizures.
Pain, and I missed what you all were saying about biofeedback because I just tuned in maybe 10 minutes ago or so. But it's like nagging thoughts of my daily activities and foods that I maybe shouldn't have eaten and books that I maybe shouldn't have read. I mean, all kinds of things are going through my head, while I have this terrible headache. And the only relief from the headache or these really nagging thoughts is to go to sleep for several hours and then to wake up again. And I was just wondering if that was maybe related to what you all were saying about biofeedback.
Well, not really, because migraine headaches, especially really typical migraine, tends to be relieved by going to sleep. And that's true in patients who don't have nagging thoughts, incidentally. By the way, there's an interesting technique you might want to read about, written by a man named Benson, Dr. Benson from Boston, on the Relaxation Response is the name of the book. It's a small book, and he gives you instructions on how to clear your mind of that kind of intrusive thought. You might want to buy it.
Do you think that these intrusive thoughts are in any way related to the perfectionism and that type of thing you were talking about? Or maybe not necessarily?
There's probably a connection, but it's a lot deeper than I'm going to be able to analyze here.
Yeah, okay. The Relaxation Response by?
Benson.
Benson. Okay, thank you.
Thanks for calling.
Thank you.
Number is 270-0101. And we'll go to our next... Hello. Hello.
Hello.
You're on the air?
Okay, I have a question about... I was wondering if headaches can be triggered by carbon monoxide, because I have what it seems to be like a vascular migraine type headache, one side of the head. And it occurs... I can't figure out when it occurs at random, seemingly, but more often sometimes when I'm like going to New York City or something with a lot of carbon exhaust fumes.
Yes, carbon monoxide causes vascular headaches. Absolutely. It can be tested for. You can have your blood drawn, and the laboratory can determine your exposure to carbon monoxide. And if your level is higher than whatever the lab says is acceptable, you then could address your environment, your automobile, your living quarters and so forth, your house heater. All of the potential sources of carbon monoxide would have to be addressed.
Is there any way to ward off that headache when you're driving and you realize that you get it? Or are you going to?
Well, there are a lot of other reasons for headache when you're driving besides carbon monoxide. And it really deals with the prevention of headache in general. I think you'd have to look at the big picture, not just what do I do while I'm in my car, but what am I doing in my life in general that might prevent the headaches.
Okay, one more question.
Okay.
How do you tell the difference between do headaches caused by eye strain resemble vascular headaches at all?
Usually not. They're usually on both sides of the head. They're usually around the eyes and the forehead, and they should be correlated in some fashion to reading or the use of the eyes for close work. So that if you awaken in the morning and just as you're opening your eyes, you notice your head is hurting, you can understand that that's not likely to be due to eye strain.
Okay, thank you.
Thanks for calling. And our number tonight is 270-0101, 270-0101. And we'll go to our last caller who's standing by right now. Hello, you're on the air.
Hi. I want to say that this program is actually quite interesting.
Thank you.
Dr. Satinsky.
Yes.
I don't know exactly what's happened. I think about 6 or 7 months ago I was driving and all of a sudden I got this real bad headache right behind my ears. And I was going to the doctor's anyway for something else. And all of a sudden my vision went into, it seemed like a prism effect right around the peripheral of my vision. I couldn't see the car in front of me unless I moved my head, and it was really scary. Well, my doctor checked it, and he checked my heart, and he suggested I go to an ophthalmologist right away. I did. The ophthalmologist said that it was probably a vascular migraine. If it